This meeting is now being recorded.
Well, good evening. Welcome to the EDS Awareness Educational Webinar. My name is John Furman. Before we introduce our speaker for this evening, we'd like to give an overview of our free program for those attending for the first time. So we'll go over who we are, what is our program, some upcoming events, introduce our speaker for this evening, Petra Klinge, and then we'll have a Q&A. So again, my name is John Furman. I manage the National EDS Awareness Program based in Cincinnati, Ohio. My daughter, Deanna, also on the call, leads the Cleveland, Ohio EDS Support Group. She was diagnosed with EDS in 2008, the same year my wife passed away with breast cancer. I was a caregiver for my wife, Carol, who struggled with undiagnosed EDS for over 30 years. We introduced our program at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We've started over 90 groups to date. Each group is given their own free website with a link from the directory and map. We receive feedback that conferences provide valuable information and social opportunities that many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We meet every first and third Tuesday, typically at 7:30 p.m. Eastern Daylight Time. All the programs are free. The meeting announcement and whenever possible, the webinar recordings will be posted on our website at edsawareness.com for later replay. You can receive email announcements for future sessions by requesting the free report on our site. Tonight's presentation is sponsored by Body Support Store, where you will find over 250 products selected by EDSers for EDSers. The store is the only funding for the program and usually covers our monthly web fees. Please visit our store and check out the helpful products that we sell. Just a general disclaimer. This presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you are having medical problems at this time, please call 911 and get the services that you need. Always consult your doctor before making any changes to your treatment.
Our next webinar will be held on January 19. Dr. Patrick Agnew will present new developments in connective tissue surgery for EDS, feet, and ankles. This will be the second time Dr. Agnew has presented for us, so if you'd like to see his previous webinar, please go to the webinar page on our website at edsawareness.com to view that. Beyond that, in February, on the 2nd, we will have Trish Megan from Healy Physical Therapy present a session about physical therapy for EDS. And also in February, we will have Dr. Grubb, who is the dysautonomia and POTS expert from Toledo, Ohio, who many of you are familiar with. He has also spoken at the EDS conferences in the past. Go to our webinar page to see our full schedule and our ongoing lineup of speakers for March and beyond. For those attending live tonight, there will be an opportunity for Q&A after the presentation. Add your question at any time by clicking on the Q&A icon at the top of your screen. After typing your question, click the orange button to submit. Our speaker tonight is Dr. Petra Klinge. Her topic is tethered cord syndrome in EDS. Dr. Klinge is an internationally renowned neurosurgeon specializing in the surgical treatment of patients with many conditions, including Chiari malformation, tethered cord syndrome, and spinal malformations. She joined the Neurosurgery Foundation as attending neurosurgeon and associate professor at Brown University in 2009. Prior to that, she was a professor of neurosurgery at the Medical School Hanover, Germany, and received her medical degree at the University of Kiel in 1993 and completed her neurosurgical residency at Hanover Medical School in Germany in 2002. She was a senior associate professor of neurosurgery at the International Neuroscience Institute in Hanover, where she had the opportunity to be educated by a founder of modern skull-based surgery. She's an active member of the American Association of Neurosurgeons and the Congress of Neurosurgical Surgeons. Her scientific interests comprise the development of advanced techniques for diagnosing and treatment of dementia, experimental work to advance the understanding of normal aging and dementia, and to develop novel biotechnical treatment approaches, including stem cell therapy. Her scientific publications are listed by the U.S. National Library of Medicine. And with that, extremely pleased to have Dr. Klinge to speak with us tonight, and looking forward to her presentation. We are loading your slides on the screen, Dr. Klinge, and I'm going to go ahead and turn over the microphone to you now.
Okay. Hello. Good evening, everyone.
Hello.
Hello. The only thing is, John, I was still kicked out. I'm in again, but I guess I'm probably going to have to ask you to advance slides for me, if that is okay. Not quite sure. You want to give it one more try to get me to advance them? Sorry. Okay, so you are going to advance, John?
Yes, I will advance. Yes, I will advance your slides.
Okay, I think that is then best. Can you all see my cursor on the image?
Did you put the cursor button? Let's see. I think you'll have to start without the cursor, and I'll
okay.
try to get to it.
Yeah.
Okay.
Yeah. Okay. So that should be fine. Okay. Good evening, everyone. It's a pleasure talking to you tonight. I'd like to advance the importance of tethered cord syndrome. Oh, thank you, John. I think I click on show the presenter's cursor. Mm-hmm. Can you see it now?
Click on the show presenter's cursor one more time.
I did.
Oh, there it is. Okay, we see it.
Okay, good.
Yep.
Okay.
Okay.
Well, okay.
Perfect.
We'll get it through. All right. So certainly. So first of all, I have no disclosures, and there is not anything in my presentation that should be beyond standard of care or provide any conflict of interest. So I want to just make the point that recently, as we understand more of the neurological sequelae of Ehlers-Danlos syndrome, certainly neurology as well as neurosurgery has to become more of a focus in the management and diagnosis of Ehlers-Danlos. Certainly, I want to mention that Ehlers-Danlos and the care of Ehlers-Danlos syndrome is one of the most, or if not the disease that needs various interdisciplinary and transdisciplinary care, and that's why my slides outline all these specialties that are of equal importance in the care and understanding of EDS. So, but coming to the point, I'd like to start my lecture with a recap on what tethered cord is, and then also what occult tethered cord is, because that's what we're dealing with in the Ehlers-Danlos population is mainly a hidden tethered cord that you cannot see on the images, but the person suffers all the symptoms of tethered cord syndrome and will go over those symptoms. Most important is, as we treat more of those conditions, we need to support more evidence that occult tethered cord syndrome and Ehlers-Danlos syndrome actually exists, not just to prove it to the healthcare system, but also to prove it to other physicians, to prove it to other specialties, and certainly ultimately to improve outcomes for the patient. And the third area is a little bit about how we practically approach and decide surgical indication and management of tethered cord. And then I was going to present some areas of research that are currently going on and hopefully will increase the excitement of the medical society. So I always like to start my presentations in reminding us what is tethered cord, and to remind us that tethered cord actually starts very early in our life, basically when we are still embryos. And what happens is, and that is a phenomenon that is as exciting as it is, can go wrong probably more often than we know it goes wrong, and probably more people have tethered cord and walk around and they don't even know it. So what happens when we are 6 weeks of gestation, this is seen here as an embryological stage, our spinal cord that is kind of evolving in the midst of our embryological length, so to say, extends all the way down to our tailbone. And so initially our spinal cord is all the way down to the tailbone, as shown here. And as we then grow as an embryo, what happens around 10 weeks of gestation, the caudal, the distal part of the spinal cord dies. There is necrosis, meaning that the cell dies, and the spinal cord again decreases in size. First, the spinal cord extends all the way down to the tailbone, to our butt, and then again it decreases in size, and then brings the spinal cord to its final length, and that is called retrogressive differentiation. And this is the process where a lot of things can go wrong, because while the distal part of the spinal cord is dying off, a lot of tissue that's not supposed to be there can remain in that distal part. For example, fibrous tissue like fat, muscle, bone, and if that is the case, then we are having a problem with what remains of that spinal cord residuum, so to say. So basically, what I'm saying is, if all goes well, and forgive me, I'm sometimes having some busy slides, but I point to the main message, is if all goes well, we have like, this is our, like a sketch of the spine with the vertebra here, and the spinous processes here, and the yellow piece is our spinal cord, and that's what the real spinal cord is, and what comes out of it that was originally also spinal cord, but that was the part that has died off and has necrosed, and it's just like a collagenous string, like a collagenous fiber. And this should show, just like wavy collagen fibers that are supposed to be there. And if you go into the textbook, it says the phylum is a fibrous, collagenous, and elastic band that connects the conus, which is the distal tip of our spinal cord, with the dual sac and stabilizes the spinal cord. Whatever that means, we still don't know why our spinal cord needs to be stabilized, but that's what's in the textbook. So that phylum goes down there and connects our spinal cord with the tailbone. What happens is, as I just said, when we are born, so then we have the spinal. This is another sketch. The spinal cord is ending here. We have the phylum connecting the spinal cord to the tailbone, When we are born, the spinal cord is still like in the upper lumbar area, but then when we are adults, we expect the spinal cord to not be anymore in the lumbar level, so the spinal cord should move up to the thoracic area. This is when we grow. When our spine grows, the spinal cord moves up, and we suggest that the collagenous phylum gives way to allow the spinal cord to rise with the lengthening of the spine. So that's what's happening. So this is the normal situation, and then what we expect normally, and I'm showing some MRI pictures because they are so important for you to understand later how a normal and an abnormal MRI will look like, and it should also bring to you the message that these days the MRI is the standard imaging to assess or to assess tethered cord, to prove it or to exclude it. So what I'm showing to you here, and bear with me for a second, is these are two important pictures that need always to be done when we want to look at tethered cords. This is an image where we are looking at the vertebra and at the spinal cord from the side, and this image is like showing axial views, meaning that we go slide by slide, through all the levels of the spinal cord. Why is it important? Because I just said that we expect the conus in an adult to be at a certain level, and it shouldn't be in the lumbar level anymore. It should have moved up to the thoracic level. So with this image, I can actually assess how far down the tip of the spinal cord is. If you look at this image here, this line is the spinal cord. All what is white is cerebrospinal fluid, which certainly our spinal cord is bathed in spinal fluid. And when we go through those images, like in slide by slide, I can exactly know where the conus ends. And it's very important. And we usually wanted in an adult the conus to not be lower than the second lumbar vertebra, which is somewhere here. So this is one important image to assess the level of the conus. The second important image is to see whether there's something wrong with the phylum. Remember I told you that the phylum hasn't really formed in the way it should with just harvesting collagen. It can have fat, bone, like it can be thick. It can have all sorts of like tissue that's not supposed to be in there. And that can be seen in that image. Here, the spinal fluid just jumped from this to this. Spinal fluid here is white, and here we have spinal fluid dark. That's an important image because fat, for example, or any other elements that are not supposed to be in the phylum would lighten up in that image. This is a normal image, but in my next slide, I'm going to show you an abnormal image. But just so you know, you should always ask for these two images, and that's what we now perform in a standard fashion to make sure that we're not missing any abnormal structure in the conus level or within the phylum. So as I said, if it doesn't go well, we have an abnormal phylum and a tight phylum. So this is shown in this sketch here. So again, the sketch with a normal vertebra, and also what I just said, the conus being at the upper lumbar or thoracic level and the collagenous phylum coming out there. And then here you see, if you compare this, that if the phylum is too thick and too tight because it has all abnormal tissue in there, it's kind of thicker. It sometimes has fat in it. That's why it's colored yellow here. And as you can see here, it then acts like a rubber band, and it kind of pulls the spinal cord down. And the tip of the spinal cord is much lower than, as you can see here. And that is abnormal. Also, I'm going to jump to MRI pictures here. where you can see this is the tailbone down there. That is the same image that I showed you, and you can already see here that the spinal cord seems like all the way down to a level where you already have your tailbone. Basically, what we have when we are 6 weeks of embryo, where we have our spinal cord all the way down to the tailbone, that's what can persist if our phylum does not undergo the usual retrogressive differentiation that I explained to you initially. And then sometimes we have, maybe it's hard to see, but there is a little bit of a white signal within the spinal canal, and that is fat in the phylum, which is not supposed to be there. It sometimes can be just as subtle as it is here, where you hardly notice it. You would ask me, well, what is wrong with the spinal cord being pulled down? I guess you might say, well, it's certainly not good for the spinal cord to be pulled at. But the mechanism of how symptoms arise with that problem is that the spinal cord basically strokes out. What do I mean with this? When the spinal cord is stretched, the vessels, the blood vessels of the spinal cord are also stretched, and they don't supply the spinal cord with sufficient blood anymore. And then you have ischemia, that means a stroke to the spinal cord. And there are certain researchers that have done a great deal looking at experimental tethered cords in animal models, I have to say, that has helped us to understand what's going on in the stretched spinal cord. And Dr. Yamada has published several papers and has shown that basically the problem with tethered cord syndrome and what causes the symptoms is a stroke to the spinal cord, based on mechanical stretching, but that ultimately leads to blood flow reduction and blood flow impairment in the spinal cord and to a stroke. That's why we sometimes face not so much of a good outcome even after surgery, because there might be some irreversible damage and a point of no return despite good surgical efforts. So, but talking about symptoms, it's much more important now for our practical approach to tethered cord, besides, of course, all the science that still needs to be done in order to understand what really happens to the spinal cord and why is that phylum so nasty, and particularly in Ehlers-Danlos syndrome, and I will come back to that later. But of utmost importance is understanding the symptoms, because that for now helps our decision making and our ultimate decision for whether or not we're going to treat the tethered cord. So bear with me. If I say a triad, it means like you have to have symptoms in three categories. So these three categories are outlined here. So one important category is neurological signs, which means signs in your lower leg. And the facts that I'm presenting to you now actually stems from the pediatric understanding of tethered cord, because these are like, these where we have all the knowledge of tethered cord from, because classically we have been treating tethered cord in the kids. That's why I put up that little cutie here that I have downloaded from Google. You see lower leg signs in infants, decreased leg movement, absent reflexes. In toddlers, abnormal gait, delayed walking, in-toeing, loss of ankle control. A lot of, parents say, oh, well, yes, there was always like in-toeing, and she was kind of having like, when she was walking longer distances, the feet turned inward and the toes were curling up, and everyone thought that was just a developmental thing. But now in hindsight, that we learned more about it, we understand that this might be, in fact, tethered cord. Teenagers start to have pain, asymmetrical motor dysfunction. They start to say, I'm limping on one leg is kind of a little bit numb and given up on me. Asymmetric findings, like just one leg and not both legs, is very typical for tethered cord. And then as young adults, you have like hyperreflexia, meaning that your reflexes are elicited and you have some higher tone in your legs and a lot of pain in the legs. The second part of the triad is urology, meaning a neurogenic bladder, which either means like you have to go to the bathroom very often, you don't empty your bladder completely, you don't feel that you have to empty your bladder, and you have accidents, you are losing, your urine unconsciously. Also, constipation is very important. And in the pediatric population, if there is, for example, in a person suspicious of tethered cord, if a person has more than 3 urinary tract infections per year, that is very suspicious and usually ultimately makes us doing the surgery. And the last part of the triad is ortho, which means like either scoliosis, kyphosis, or any like leg deformity or asymmetry in foot length. And also sometimes in the toddlers, we see delayed or plateau in growth, which is unexplained. And then sometimes the endocrinologist does a whole deal of the workup and doesn't find anything. And then I have 2 kids where surgery was done and they ultimately started to grow after the detethering procedure because they were just not growing because of the tethering, which a mechanism that is still not quite clear, but it's interesting. And then, of course, the subjective pain, as I just said, back pain and leg pain, complaints. And very important is, and I sometimes teach my colleagues even that, sometimes dismiss a person if a person isn't able to explain, where the pain is exactly going. It's not a sharp pain. Tethered cord, you usually have aches and burns. Your legs feel heavy, they are stiff and tight, and then all these symptoms are traveling. So you say, oh, on Monday it was my right leg, or Tuesday it was my left leg, and now it's down there, but sometimes it's up there. So no one should dismiss traveling and fluctuating pain because that is actually tethered cord. It's quite typical. And unfortunately, that sometimes confuses the doctors as well as does confuse the patient. So we have to be much more vigilant about it. And the symptoms are very important, as I just said, and also the screening is very important for tethered cord. And it's not just the MRI and the symptoms, but we also have to look for indirect signs in the lower back, like cutaneous signs, or we also call them neurocutaneous markers for tethered cord, which is like a little dimple or just like a double butt crest or asymmetric butt crest, some discoloration above the butt with the deeper dimple. Sometimes the depth of the dimple varies. But all in all, I just want to remind us that we should search for those cutaneous signs, and particularly in patients that do not display a lot of MRI findings of tethered cord, like with a low-lying conus or a lot of fat in the phylum or whatever abnormal signal in the MRI. These are our saviors in order to support that we are probably dealing with a tethered cord. So that is just a classical view, and wanted to remind us all that we are coming from the pediatric field here. But now I have to jump to occult tethered cord, which is again symptoms consistent with tethered cord as reviewed. I just spent a great deal on explaining to you the triad and the subjective traveling of pain and the aches, burns, and not the sharp pain. We certainly want to exclude other conditions, so we have to do an MRI because we want to make sure that there is no tumor or anything else going on in the spinal cord. But essentially a normal MRI. That's what we're also dealing with in Ehlers-Danlos patients. And so basically it's a clinical syndrome of tethered cord with little radiographic evidence. And I'm not going to repeat those scans because I reviewed them with you, but I'm just going to repeat here. Don't forget, we have to get these sagittal and axial images, both in the scan where you can see the fluid white, because that gives you the level of the conus. It's so important. And even like subtle abnormalities on the level of the conus should already raise suspicion. That's why you have to be very thorough, and you have to discuss it with the radiologist. And then this sagittal and axial, where you kind of scroll through the phylum, and any fat spot in that column, like a little white spot in this area here, is a little fat, and that should raise suspicion of tethered cord. Alrighty. So where does occult tethered cord syndrome come from? And again, that gets me back to the pediatric world. These were the front runners. And Paul Steinberg, and I have to pay credit to him and not to anyone else, because he was the one that first kind of brought up the concept, with others, of occult tethered cord. At the least in 2013, he wrote a nice review about the occult tethered cord in pediatric world. And my point is, and my message to you is, that all the knowledge that we have from the occult tethered cord syndrome in the pediatric world can be translated in EDS management, not just in the children, but also in the adults with EDS. And my experience so far has shown me that that is true, and we really have to be grateful that this tethered cord syndrome has been identified quite thoroughly, at least in the pediatric world. I have to say it's still controversial, but a lot of people do think that we have sufficient evidence to understand that this is truly existing. So I want to show you that back in the 2004 or even in the early 90s, imagine, the occult tethered cord syndrome was already described. And the largest experience, of course, is from Monica Webby. She has 60 kids, which she reported. They all had a urodynamic dysfunction. They had nothing on the MRI. And in 58 of those patients, 58 of 60, there was improvement of the urological symptoms. So that kind of really, really brought it up and got people excited about it. And the indication was basically, as supposed and proposed by Monica Webby, was that you need to have symptoms, either in the neuro, ortho, or uro or GI, or you need to have like a neurocutaneous sign, which I went through those earlier. And if you have 3 of those 4, then surgery can be recommended or can be discussed even without anything in the MRI. But if you only have like 2 out of 4 and not the complete, try it, you want to see something in the MRI, whether you have a progressive scoliosis or you have some fluid buildup in the spinal cord, which is called syringohydromyelia, that speaks for the stroke of the spinal cord, or you want to have like something in the phylum, maybe a thickened phylum. More than 2 millimeter is already too big for a phylum. A phylum should be less than 2 millimeter. That's why we have to do those diligent MRIs that I have shown to you. So you really have to look into it in depth, not just like in 1 second. Or you have some spina bifida occulta, which can be seen on the X-ray, which basically is that some parts of the spinal column haven't fused, which is also an indirect sign. So going back to Webby, that's her in 2004, like seminal work, with all these very strict criteria, she had shown that in 50% of the kids, the urinary incontinence has completely resolved. There was marked improvement of the urinary incontinence, meaning like almost complete resolution in 35, and then moderate improvement in 6%, and no improvement in only 2%. So she applied very strict criteria, though, to the urodynamic dysfunction. And that is also important how now we look at occult tethered cord. What is also important is that weakness, sensory abnormalities, and pain resolved in all patient, which is really quite exciting. So we have some supporting evidence of, so basically, what is the supporting evidence of occult tethered cord syndrome in EDS? And we have quite some evidence. And the first slide is the slide that I have just shown to you, if I just go back, where I showed you the criteria for the pediatric world. So how can we translate this in EDS? And I was going to say, and people do agree with me, at least those that have experience with EDS, and when we discuss it in our meetings, is that certainly we have to not go by the strict criteria that stem from the occult tethered cord syndrome in the pediatric literature. We have to we have to embrace some EDS specific problems that might be a sign of tethered cord but haven't been described so far, because we're just trying to seeing it, and as we see it, and as we see it get better with the surgery, we learn that this is probably EDS specific tethered cord syndrome, if that makes sense. And here the thought is that probably a lot of the musculoskeletal manifestation, including the peripheral neuropathy that with the traveling pain, which originally was thought to be like just a manifestation of the tissue laxity in the muscles and the peripheral nerves that cause increased joint subluxation and ankle deviation and peripheral pain, neuropathic pain, is probably all tethered cord. This is a very provocative thought, but I just want to bring that out here, and we have to look more diligently and more thoroughly to it. And it might even be that the craniocervical manifestation, the so-called Chiari problem that we have with all the abnormal clival axial angles. I don't have to explain to you this picture because I know you know better than I what's happening in the craniocervical junction. And so maybe this is also part of the tethered cord, because if the spinal cord is pulled and it strokes out, it might weaken all the muscles and not just down the lumbar spine, but also up to the craniocervical junction, and might be part of the problem why we're having the craniocervical junction abnormalities. And the thought is that tethered cord might also release part of the craniocervical abnormality, but we don't have a proof yet. So don't think that I'm making that statement. We'll have to look into it. And it could also be that all the pelvic weakness and the instability, which was also thought to be pelvic instability and laxity, and the increased or decreased bladder compliance that is seen, might be tethered cord. And certainly we see pelvic floor weakness, and that might certainly part of it is tissue laxity. But in addition, there might be an element of tethered cord, and that might add to the mix. It might add to the problem, and it can be taken out of the mix if treated. And then certainly in EDS, we should definitely watch for cutaneous signs, because they might help us to further establish the treatment indication. So basically, in terms of the tethered cord syndrome and how it presents in EDS, we have to get more evidence, and we have to look more into it and technically, scientifically gather the data. And all the symptoms need to be registered and put into a database to further understand. But so far, we do have evidence that sometimes when we do the surgery, even if we don't see anything in the MRI, in EDS patients, intraoperatively, we see quite a bit. And I was going to show you a few patients. I'm going to go quickly over it in interest of time. A 5-year-old and an 18-year-old, both EDS. The 5-year-old had pain, progressive weakness in ankles. He needed an upgrade in braces, a progressive leakage, even though he was potty trained once. And even though urodynamic studies did show grossly normal findings, but they were done under anesthesia because the little guy hadn't tolerated the urodynamic studies. And then 18-year-old, she had progressive Chiari pain. She had a 3-millimeter Chiari, not so overwhelming, but doesn't always have to be. Leg aches and weakness with traveling pain, progressive scoliosis, and reduced bladder capacity with low compliance. That's at least what the urodynamic studies show. Both underwent surgery. The little guy had the conus at the normal level. The phylum was a little bit thick. It was more than 2 millimeters. That was something which was supported in the MRI. And there was maybe a teensy fat signal in one of the axial slides, but not really overwhelming. But if you look at this here, you can see that it's an intraoperative finding, but bear with me. I'm looking onto the nerve fibers, and these little tiny structures here are the nerve fibers of the cauda, that's all the nerves that come out of the spinal cord. And you see that white line here? That is a very thickened, fatty, infiltrated phylum, which was not seen on the MRI. And a phylum is normally not seen. Once you get in there, in the normal person, you would not expect to find the phylum. So what I'm saying here is, intraoperatively, we sometimes see more of what we see in the MRI. So we cannot really trust the MRI all along. We really have to go by the symptoms. And I'm repeating myself here, but I think I went very thoroughly through the symptoms with you. So what the surgeon does is kind of hooks up the phylum, with a little nerve hook. And then what we always do, we have a little electronic probe. We stimulate the nerves to make sure these are the nerves, and we stimulate the phylum, and we don't want to hear any nerve signal on the phylum before we cut into the phylum. This is our micro scissor. We cut and disconnect it from the cord. The cord is here. And then also we cut that whole piece of the phylum is going to be cut out because, and this is the phylum that's taken out, because we really want to make sure that we have a big piece out. We want to really disconnect it in order to not have it get reconnected. And then you see a little stump of the phylum, which now the spinal cord here is relaxed and released. This is the last part where you don't see any phylum anymore. You see happy, hopefully happy, all organized and structured nerve fibers here in the spinal canal. Excuse me. So this is the girl, the 18-year-old. She had nothing on the MRI, not even a thickened phylum, no fat in the phylum, so all normal. And again, as you can see here, again, the phylum hooked up on the nerve. The phylum is not as prominent, as thick as in the little one, but certainly it looks like a little taut. It is kind of stretched and tight appearing. As I said, usually the phylum is kind of all the way within the nerve fibers, and you would not necessarily see the phylum right away. All right. Oops, I'm sorry. So in the interest of time, I just wanted, this picture really should show examples of EDS patients that had nothing on the MRI, and the phylum was either too thick, because usually the phylum is not thicker than the nerve roots. So this looks like really like a stick in there, or it is taut and thin, like kind of stretched and tight, and sometimes, as I said, too fatty. And this should just summarize to you that we see intraoperatively more than the MRI shows, and that's why these days we like to document the intraoperative findings, because they will also shed further light on that we are not dealing with the normal phylum. What about the surgical outcome so far? And here I can only tell you from the two patients that I presented to you that this little guy, after the surgery, had normal voiding, no urinary leakage again. I have to say that his pain is not any better, unfortunately. Still has some weakness, but the urinary incontinence is gone. And the parents state that this has really changed their life so far, though they're still dealing with the pain. The 18-year-old girl has gotten rid of her Chiari pain. Just to remind you, I told you, it could be that tethered cord has remote effects on the craniocervical pathology and the craniocervical angle. So probably the tethered cord relief should be favored over initial intervention in the craniocervical junction. But again, that has to be proven, but it certainly also is dependent on how bad the craniocervical junction looks like, and sometimes certainly that needs to be addressed first. The leg aches and the weakness in the legs had gone away, and also the bladder capacity and the low compliance has gotten better, as evidenced by the urodynamic studies. So there is improvement, both subjective. There we see reduced leaking of the bladder, improved bladder control, improved posture. Sometimes there is posture-associated chest pain in some EDS patients, and after tethered cord release, there is report that the chest pain had gotten better. Joint subluxations might get better, less curling of the toes and the ankles. Physical therapists sometimes describe that they have a better moment to control the ankles and the joints. As you know, that we are here in Rhode Island. We have the blessing to have two physical therapists that had also spoken to your group, which are excellent, and they kind of report that things do get better under control after tethered cord release. And then it might be that craniocervical symptoms get better after tethered cord release, improved balance, reduced falling space, spells, improved pelvic stability, and facilitated physical therapy, as I just said. This is the experience I have so far with not a large number of patients, but this is just, but I cannot show the video, but I think...
yes, the video does work. Go ahead and click on it.
Oh, really? Okay. All right. This should just show... Oh, good. Thanks, John. So this is a patient who allowed me, and he wanted me to show whenever I can this picture. It's after tethered cord release. This patient was not able to do any of this controlled, like moving of that device here while stabilizing her pelvis. And also here, these are very sophisticated balance exercises that she's now able to do after 3 months after the tethered cord release, due to improved balance and stability in the hip joints and all the other joints, and certainly probably also better proprioception and all these neurological sequelae. Certainly the greatest experience has Dr. Fraser Henderson, whom most of you know, I'm sure. He is the father of all this, and certainly wonderful physician. And he just recently, and he actually allowed me to show his slides, I don't deserve any credit here, about a survey that he had undergone with patients that were treated by him from 2010 to 2014. The response rate was only 36%, but he got out some exciting results where he can show that low back pain also has decreased quite a bit. This is a pain scale. The higher the number, the worse the pain. And preoperatively, these are the blue bars. Most of the patients were in the higher range of the pain scale, and then they dropped postoperatively to the orange bars, which are lower numbers in the pain scale. And this was quite intriguing. Also, in all the symptoms that the patient displayed prior to surgery, there was quite a reduction in those, as you can see here. So this is the percentage of patients that suffered from a respective symptom. Blue is preoperatively, orange postoperatively. So this is loss of sensation in the lower limb. While 90% were describing it before the surgery, only like 50% was describing it after the surgery. Urinary incontinence, 60% before the surgery, and then only 25% after the surgery. Symptoms on stairs, climbing up the stairs, leg weakness, limited walking, tripping, urinary frequency. So you see that all the bars trend down post-operatively, showing that there is improvement in all dimensions. And the highest, or the symptoms that shows improvement in the majority of the patients is leg strength and walking. And I can confer with Dr. Henderson's results. I also do see that patients say they walk better, they feel that their legs are their own again, they have better control, and that is truly something that is seen. He asked the patients about the satisfaction with the procedure, and 60% were extremely satisfied, and the rest were somewhat or reasonably satisfied, and 80% at least of those that responded. And you might say there could be a bias in there because only 36% responded. Could that be those that were satisfied? I guess could be, but at least these are some data, and from now on we certainly have to evaluate that in a prospective fashion, clearly. But that's what we're going to do. So here, my interest was always in histology. And I want to spend the next 5 minutes before we go to our last slide about very interesting histological findings. So as you recall from my surgical pictures, because as a pediatric neurosurgeon, we usually agree that we're going to take out a piece of the phylum again to minimize the chances of retethering. So I always take out like 1 inch of the phylum if I can, and then I send that to pathology. And I thought, we should look at the phylum, because given that you don't see anything on the MRI, or not always, the phylum doesn't always look so abnormal on the in the intraoperative view, but often it does. But what is wrong with the phylum in EDS and in the occult-type phylum syndrome? And certainly I can do that with the phylum, but I also have to have some knowledge how an abnormal phylum classically should look like. So what do we know how like a classical abnormal phylum should look like in those children or other people that have a tethered cord in a classical sense, where they have a fat, or they have a low-lying conus, or they have a thickened phylum. So we have a lot of evidence how an abnormal phylum looks like. And there are some studies from Turkey where they had looked at normal phylum from stillborn embryos, and this is the table of that study. I don't go over it in detail, but they compared it to patients that suffered from tethered cord and where they had like actually excised a thick and abnormal phylum. And the main message is here: fat is certainly not supposed to be in a normal phylum, so fat, but also dysplastic nerves and some inflammatory cells, they're not supposed to be. So inflammation, fat, muscle, and a lot of dysplastic nerve fibers are not supposed to be in the phylum, in a normal phylum, but it's seen in an abnormal phylum. And there's a very neat study done in Portland by Dr. Sheldon. He showed that in patients with tethered cord syndrome and with urodynamic problems, you see abundant fat in the phylum. So basically, the more fat in the phylum, the lower was the conus, and also nerve fibers and fat were associated with abnormal urodynamics. So we know how an abnormal phylum should look like. And what did we find in the phylum in EDS? And based on some advice that I had gotten from Ann Maitland from Maryland, she is an allergologist, very knowledgeable of mast cell activation syndrome. She told me, don't just look at fat or at inflammation or at the vessels, and don't just look at collagen and elastin. Also look at inflammation, because in EDS you might find something there, because she hypothesizes that the mast cell activation disorder or just having EDS might cause inflammation of the nervous system, and we might find something in the phylum there that lead us to understanding what's going on in the spinal cord and the brain and in the brain stem of patients with EDS, which might eventually help us to understand what is really wrong and what's going on. So I did as suggested, and I found inflammatory changes there. The first thing I found is, I'm going to jump right into this. So this is the phylum. That is a H&E staining, which means like hematoxylin and eosin, which is the most standard stain that you could do. And you see the collagen fibers here, wavy collagen fibers. Remember, my very first slide showed that this is quite normal. You would think you should see wavy collagen fibers, but you wouldn't see like big vessels, like vascular lacunes. That is not really in a phylum. And then this little arrow shows that there is a neutrophil crossing the border of the vessel and moving into the phylum. That's what you would not expect to see. A neutrophil is a cell in the blood that usually is the first line of defense in inflammation. And it shouldn't be in the phylum, because we don't expect inflammation to be in the phylum. Certainly what we also found is that we have breakdown of the elastic fibers. You can hardly see it here, but trust me, the elastin fibers are all like disrupted. Usually they are also wavy as the collagen fibers, but this is a stain of elastin fibers, and they look like you break sticks and you just throw them back onto the floor. So it's all disrupted, and the elastin collagen ratio is diminished, which is also not normal. And when we do electron microscopic studies, which it's still work in progress, we see disintegration of the collagen fibers, which certainly might be a sign of that we're dealing with a connective tissue disorder with abnormal collagen. But if we also find it in the phylum, that might tell us something. And that is, again, work in progress, and hopefully in a year from now we have better answers. But let's get us to the inflammation. In all the EDS phylum, we see these blue dots here. These are all islands of inflammatory cells. You see the islands of fat, by the way, which is also seen in EDS if you just look closely to it. This cannot even be seen intraoperatively, but then when you do the section of the phylum and the pathologist looks at it, he finds fat. This is also not seen. So the phylums are abnormal, but besides the fat, there's also a lot of inflammation. And when I did what Dr. Maitland told me, to look at lymphocytes, which are usually, cells that react to something abnormal in tissue, we found that there are a lot of, these are the brown spots here, lymphocytes everywhere in the phylum. They are also not supposed to be there. Though I have to confess that not everyone had looked at it. As I just said, I got the advice to look at inflammatory changes in the phylum by Dr. Maitland, and maybe we should now just look at other tethered cord phylum, which is not EDS associated, to see whether we see the same things there. We also see macrophages. Macrophages are cells that usually eat junk from our body, and they are also in the phylum. As you can see here, all these these brown like little dots are macrophages, quite a bit. Like here, it's all like brown. So something is there that makes the macrophages to go in there. And now comes the real exciting thing is the mast cells. So Dr. Maitland told me that one stain for activated mast cells, these are those that are the bad guys in the mast cell activation syndrome or disease, are the mast cells that stain with CD117. This is a marker that you stain cells with, that the pathologist does, and they are actually in the phylum. You see them here. And to not fool myself, I said, well, are these guys really mast cells? And I did do the most standard staining for mast cells, toluidine staining, to make sure, are there really mast cells in the phylum and not a false positive staining? And yes, here are mast cells in the phylum, these guys here. And again, not supposed to be in there, or at least so far not described. And we have to think of, again, a lot of mast cells here, also near small vessels, and here also these dark black spots are abundant, quite a number of mast cells in there. So I did already compare EDS phylum with non-EDS phylum. These are EDS phylum and these are non-EDS phylum. And 3+ means a lot of mast cells. You see, and 1+ means only a few. You see that there is a little bit of a preliminary difference. So EDS patients seem to have more mast cells, like 2 times a lot and only a little in the non-EDS. So again, I'm telling you that is work in progress, and I will report on that. And certainly I'd ask you to support that. And you are kind enough to allow me to present that and also to report that should we have the evidence. So what is the evidence on tethered cord syndrome or occult tethered cord syndrome in EDS? And what is the supporting evidence for now? I would say that, as I just said, sometimes in the OR we see more than the imaging says. So we cannot dismiss tethered cord syndrome in EDS based on the imaging. And remember that little guy that had this really, thickened phylum with all that fat in there, and we didn't see it on the MRI. Besides, we have histological support that there's something wrong with the phylum. Besides the classical support of fat, which is also there, we have abnormal clusters of inflammation. We have vascular penetration of neutrophils, which are first-line defense cells of something inflammatory going on. We have mast cells in the phylum, and we have abnormally structured and disintegrated collagen and broken and disorganized elastin. That is evidence of abnormal pathology. And the last evidence, besides intraoperative findings, which are abnormal, besides histological findings, which are abnormal, we have outcome that shows over improvement in all the dimensions of the disease. So what are we going to do with all that knowledge now? We have some knowledge. Certainly we have to improve our knowledge, but how do we currently practically approach? Certainly in the ideal world, and this is a slide that I've stolen from the from the conference of the National Foundation in Baltimore this August, which I have to say I learned a lot, and it was a very exciting meeting. Certainly, in the ideal world, every hospital should have a hypermobility unit. That's not going to happen that soon, but as I just said, it's an interdisciplinary workup. But we have to, as we increase the knowledge about the problem with EDS, and hopefully the healthcare providers and the healthcare system will help us to establish better care, we eventually will have hypermobility units. For now, the algorithm for surgical decision-making, as we, for now, have structured this in Rhode Island with the help of some people around here in Rhode Island, which they all deserve credit, we go by the criteria of occult-site phylum syndrome, which is the checklist. Remember, I told you if you have 3 or 4 qualifiers in the neuro, or GI, and also realm, then you most likely have tethered cord syndrome. Ideally, of course, we want to have bladder and bowel signs and symptoms supported by urodynamic studies, but based on the pelvic floor weakness and the reduced compliance of the bladder that we have in EDS, we might not get the classical urodynamic studies. So that is certainly a problem. So we might need to stretch the truth here a little more. If you don't have bladder and bowel signs, certainly you want to have something in the imaging, though we have to be very thorough in the imaging. We have to do those dedicated imaging to look at the phylum, thickness of the phylum, maybe a little bit of a borderline low-lying conus, maybe some non-fused lamina, which speaks for a cold tethered cord, or even like a skin tag, like a dimple or something. So these are the criteria from the pediatric world that we have so far. We have to go by that evidence as much as we can to not, fool ourselves and not make unnecessary surgeries and wrong decisions on your interest and on your behalf. Certainly, we cannot exclude POTS, craniocervical instability, mast cell activation syndrome. If anyone comes and says, oh my God, we'll never figure that out because in EDS we have all these comorbid symptoms. Yes, we do have all these comorbid symptoms, but yet we still have to figure it out and see what part tethered cord plays in all that concert. And usually, sometimes if there's not enough certainty, I recommend to just watch a person. And if there is progression of tethered cord-like symptoms within the last 6 months, then you might think that this cannot just be some lingering comorbidity. There might be a neurological problem, and you might want to consider tethered cord release. Or if there's no progression and the person is stable, you're good to monitor, and I think everyone will understand that. Certainly I would wish that in Rhode Island we're going to have an upright MRI, and that allows us to do extension and flexion images, both for the craniocervical junction, but also for seeing how the conus moves up and down when you bend and extend, because these might be the more reliable image. So I think in EDS we cannot go by the standard imaging anymore, and hopefully these images, the extension and flexion upright MRI, will in a few years from now give us a better understanding. And maybe then we have positive radiographic images, but that is just maybe wishful thinking, but we have to look into it. But I'm certain it will. Certainly, besides better imaging, as I just said, we have to have guideline and consensus statements. Dr. Henderson and myself, with many other doctors, are working on a consensus statement, what we think the tethered cord syndrome is and how this applies to EDS. As you know, there will be in New York that big international meeting, and I hope that by then we will be able to come up with better consensus, because that will all put us all on better ground, and sure by that we will succeed in making all of the care and management better. What are areas of research? Is certainly I'm excited by the finding of the mast cells, and I'm not going to make any conclusions right now about those findings in the phylum, but it's concerning, but also exciting, because it's a real phenomenon, and that might put us in a spot where we understand that what's going on in tethered cord in EDS, and specifically for EDS, because it might be a different situation than in the classical tethered cord syndrome. Dr. Maitland pointed a paper to me where we understand now that mast cells, and this is conflicting with or contrary to old school thinking, that inflammatory cells like mast cells and lymphocytes usually don't have access to the brain, only if the brain is really like almost about to fail. For example, in meningitis or in a brain tumor or in significant brain swelling, inflammatory cells have access to the brain, but not in the kind of healthy brain. But we know now that there's much more interaction between the peripheral blood system between the body and the brain. The brain is not that privileged anymore as we thought. And so the brain can react to inflammatory stimulation. The brain is in some sort of pro-inflammatory state. So it could be that the brain in EDS is much more susceptible to inflammatory changes going along with EDS, particularly if we have mast cell activation syndrome. And so mainly the phylum is just reflecting what's going on in the entire nervous system. So could it be that the tethered cord syndrome is not caused by a fatty and thickened phylum, but by an inflamed phylum, and that the more inflammation is going on in the phylum, the more the phylum tightens up and gets tighter and ultimately leads to more tethering. So it could be that tethered cord in EDS is acquired and not congenital. That is the research question we have, but I want to finalize my lecture with the notion that certainly a lot of things needs to be done, as you can see. I hope you have some insight, and I understand that we are working on a lot of things. I'd like to repeat something that I learned in Washington during the international conference, a national conference, sorry. If you cannot connect the issues, think of connective tissue. And when I was a medical student, I was so excited about the connective tissue. And I thought, gee, what a universe. And I learned that the connective tissue harvests all these lovely cells, the macrophages, the mast cells, the fat cells, which can be good guys and bad guys, depending on what's going on in the body. But then I turned into a neurosurgeon after I finished my medical school, and I forgot about the connective tissue at all. And I said, well, the brain, what a fascinating universe. And it's so privileged. But now with all what's going on with you and with EDS, and we understand that the brain is not that privileged, and that all these cells might have access to the brain, and we just have to further research to get more insight into it and to help. Thanks for your attention.
Thank you, Dr. Klinge. What a brilliant presentation. We're so appreciative to have you talk to us tonight. And our over 70 attendees are listening intently, and they have logged some questions for you. And we have probably almost 30 questions already, and you can see how many you're able to get to. If you go to the Q&A box and pull up some of those questions, we'd really appreciate your thoughts.
I'll go to the box. I hope I see that. Okay, I'll see. So I'm going to start reading them and answering them, okay?
Yes, thank you.
Yeah. So the first question is, can someone with EDS have Chiari, tethered cord, and craniocervical instability? Will physical therapy help all three conditions, or surgery is necessary to correct all of them? Well, so certainly one can have all three of them, and I truly believe in physical therapy. What I just said, I listen to the physical therapists quite a bit, and if they fail, that they plateau with physical therapy, and the physical therapy is not as successful as it was before in getting alignment or joint stability, I usually take that for a sign that there might be something neurological going on. I don't think it is always necessary to correct all of them. I do feel that tethered cord is probably more prevalent than anything else, and usually I recommend doing tethered cord release if there is tethered cord syndrome. And even if there are Chiari syndrome and tethered cord syndrome in conjunction, I usually recommend doing the tethered cord release first. But here, not everyone agrees with me. I just wanted, for full disclosure, there are different opinions amongst neurosurgeons. And the next question was if you can have tethered cord syndrome without urodynamic involvement. Yes, I think so. And we, in the pediatric world, we sometimes have tethered cord syndrome for example, in spinal bifida patients, that we not always wait for urodynamic involvement to come because we're just worried that they might then be irreversible. But for now, given that we are still not having all the full understanding of the tethered cord syndrome, I think we have to do urodynamic testing. Even if the urodynamic testing is not quite conclusive, we might still, going by the other symptoms, offer urodynamic, might still offer tethered cord release, but I would not do tethered cord release without a testing. Again, even I know it's uncomfortable, but if you haven't done any testing and you do the surgery, it's not appropriate, because let's say after the tethered cord release, you're going to have bladder symptoms. How are we going to judge it? We have no baseline, and then that is not standard of care. The pain meds or alternatives to deal with, here I usually collaborate with 2 pain doctors which are helping me right now, and if you want to have more specific information, you're very welcome to contact me directly. And what else? How do I find a neurosurgeon to evaluate for tethered cord? Well, I'm very happy. I'm very happy to. I mean, that Dr. Henderson is tethered cord expert, and I see patients from abroad. Sometimes, it's not always easy to get the approval for that. I think it's a little bit too much for now, because I want to answer all the other questions. I guess, I don't know how you have my contact, but if you are welcome to email me, and I can have my secretary work on an appointment with me. Just understand that I start to be very busy, so you have to give it some time. But contact me per email if you wanted to have an appointment with me. Do you know a neurologist? I only have neurologists here in Rhode Island and orthopedics that know EDS, but I don't have a lot of knowledge about outside neurologists. I have a pediatric neurologist, an adult neurologist, and an orthopedic surgeon here in Rhode Island. Question is, what is a fair trial to help with these issues before considering surgery? Yeah, well, again, I'm saying that basically what I do now as a workup for tethered cord, I do the upright MRI, an extension flexion, and the MRI in the standard way still, and then urodynamic testing, and then go from there. But as long as possible, we should strive for medical management and not jump to the conclusion right away to do the cord release. If physical therapy and pain management can stabilize symptoms, then symptoms are not that progressive and are stabilized with physical therapy and pain management, we can monitor. All right, I'm just going to click that. Yeah. Yeah. Question was also about, next question is about, yeah, so I see a lot of questions, and forgive me if I just kind of try to sum that up, about experts in other areas of the country. We are working on that. I mean, I'm afraid I have to say that that certainly we haven't, amongst doctors, we haven't yet created like that big nationwide network. I'm sure, because I hear sometimes bits and pieces from other patients that say, oh, I've seen doctors here and there in New York. He also does tethered cord release? I say, well, I never had heard of them. So I think we are really we are right there. We are connecting, we are networking amongst doctors, and certainly if you know of one, don't hesitate, to tell me, because I'm very happy to make a contact. Because once we are moving to the international conference in New York, we really need to also have a network of neurosurgeons, neurologists that are comfortable providing care across the country, because we don't have to. It's not appropriate that you have to travel a long distance and then also battle with insurances. So I think I cannot give you a good answer now, because again, we are about to network. There is does the hypermobile. That is an important question. Does the hypermobile EDS patients present special surgical challenges for tethered cord release? I live in a major city with skilled neurosurgeons who have experience with cord tethering in the general population, but not among EDS. Would you expect a lack of EDS experience to affect outcomes or complication rates, and particularly concerning? So no. So this is a good question. So here I think so the only thing so the surgical skill is not different. The only thing, but pediatric neurosurgeons do so, you have to minimize the approach to the spine. So you should not do like a big laminectomy and remove as little bone as possible. So in EDS, I try to go in between the lamina and just shave off a little lamina to not make the spine unstable. And I also do feel that fusion is not indicated from the get-go. If you spread the word on that, then you any other neurosurgeon that is experienced in tethered cord generally would be well capable of doing the tethered cord release in EDS. I think the hesitance is more with like dealing with a special population of patients, and certainly still the uncertainty of the outcome and the still not 100% established criteria. But again, that will get better. So, but technically it is more or less as any other tethered cord release, if that answers the question. And certainly there's a question, why are neurologists, neurosurgeons generally so dismissive? I just said that based on the uncertainty, and also not the uncertainty of the outcome, but also because we have to deal with the comorbidities of POTS, mast cell activation syndrome, hypermobility, which you have to understand. And this is not just them, it's still also us. I'm certainly also concerned. Do I create further instability, or how do I handle POTS in the post-operative setting? Is the mast cell activation syndrome affecting my outcome, affecting the recovery? And you have to have a team, and not everyone has a team established. My own experience, and I have to pay credit to our anesthetists, they were open to taking care of the patient. And so we now have like a protocol, and we have like a team that is aware of the problems, and we are more proactive than reactive. But not everyone can have that. If you don't have that, and if you don't have the support by the other providers in surgical specialties, it's a concern. And then you certainly, I understand that you don't want to, take on that challenge just on your own shoulders, if that makes sense. That's why I'm saying a hypermobility unit would be great, where you have all the team just around the surgeon. I have to scroll a little quick because I have to have 10 more minutes. I'm sorry. In a patient presenting with lower body weakness and muscle atrophy, I'm afraid I don't have much experience with EMG. I have to skip that question and the evidence of biopsy, of muscle biopsy. because I think there is not much evidence, and I have personally no experience. Post-surgical inpatient or outpatient rehab for recovery. I think it could, I mean, that's my experience so far. It could be outpatient facility as long as the patient is like ambulatory. I mean, even if patients leave the hospital on a walker, it still could be outpatient, particularly if you are blessed with good physical therapists, which I am here in Rhode Island, I have to say. I don't have a protocol like right now, but we send patients back to physical therapy like within 7 days from the discharge of the hospital, and because we don't want them to not move, and certainly the part plays into the play, and we wanted people to have physical therapy right away. So I usually send them back within 7 to 10 days post-discharge. The question is, does the scoliosis show up as adolescence or is it present at birth? No, it can show up as adolescence, so it can develop. What complication rates do you see among adult hypermobile ADS patients? So there's a question, what complications do I have, So, and certainly there is the complication of retethering and the complication of CSF leak. I have to say, so far, I have to knock on wood, and I had not had any, like, these complications. Certainly I had aggravation of pain and also worsening of the voiding temporarily, where patients needed to be straight catheterized or even have a Foley for a few days, but then it had gotten better. But so far, my complication or my experience that I see is worsening of the pain, some temporary, like, voiding, aggravation of voiding problem, which I had got better, and sometimes temporary, like, weakness or like pain in the feet, which then has gotten better. But again, I'm mainly worried about creating new pain and sometimes aggravation of certain pain, which I have seen. But I have to say, so far I haven't seen any like instability or CSF leak, which certainly I don't have a long-term outcome, because long-term outcome is 5 years from now, how it's going to look, and we're certainly going to collect those experience. But I don't think that anyone has like real long-term outcomes so far. There are some questions on fusion. Why does it seem that some of us, after getting fusion at C to C2 or C, develop symptoms of OTC if we do not show signs on MRI and do not? Well, here I have a very blunt. So the question was, why do some people after fusion develop symptoms of OTC if there are no signs on MRI and there are no cutaneous signs? Well, this is a very provocative and speculative thought. It could certainly be that the fusion, since it alters the alignment of the spine, can then ultimately pushes the tethered cord over the edge. If you think that tethered cord is a problem of changes in the spine, I mean, certainly growth of the spine, but also like changing the alignment of the spine with fusion, could that then cause the tethered cord become prevalent, because you're basically changing the structure of the spinal column? That's my only answer I have. And as I just said, there's a person who asked quite some time about the signs on the MRI. Again, that's why we have to go by the symptoms, I'm afraid, and certainly losing fat, losing weight is not helping the fatty phylum. It's not that kind of a fat, so that doesn't help. So don't lose weight for that. Question is, what should be fixed first, occult tethered cord or Chiari? Well, my opinion is that if there is no severe craniocervical instability and no severe brainstem symptoms like swallowing deficits or breathing deficits, or that you have to wear a collar and you can't even hold your head on the shoulders, I believe that tethered cord release should be given the priority, certainly if you have symptoms of tethered cord. So basically what I'm saying is, if you have both Chiari symptoms and tethered cord symptoms, but if the Chiari symptoms are not severe and affecting the health in a substantial way, tethered cord release should be done first. So let me just scroll through the most important. Well, there is one person that asked that there are calf spasms, Charlie horse. Yes, that is tethered cord. So I can only say that Charlie horses are a sign of tethered cord. There was, just so the person knows who that is, it's something going on in my lumbar area. That's what the physical therapist thinks. I think the physical therapist is right, and that person should be evaluated for tethered cord. That was the person with the Charlie horse question. Hypertrophy of the ligamentum flavum is not tethered cord, at least not a sign of tethered cord. Tethered cord, the question is, can tethered cord cause a knife-like stabbing pain in the thoracic spine? Yes, it can, and it can be severe that it can cause you to trip down the floor. There's chest pain and knife-like stabbing pain reported in tethered cord. There's one patient that asked me a very difficult question because I don't have the answer. The question is, how often does tethered cord release the Chiari pain? I cannot give you the answer because my patient numbers are not that big, and I can only report that one patient that I presented in my lecture had release of Chiari pain, but I also have seen in some patients where they only had 3 months or 4 months of improvement in the Chiari pain, and the Chiari pain came back. But then my hope is that the physical therapist has a better momentum of treating the Chiari pain because I had just released the tethered cord. But as I just said, I have to be honest to you, I don't have the final answer to that. The future will tell. Hold on a second. So, yeah. There are more questions. I have to scroll through some. I'm afraid I would not be able to answer all of them. Okay. Do most patients with tethered cord have a scoliosis? No, not everyone. There are also patients with tethered cord that don't have scoliosis. But sometimes you can have just a mild scoliosis. So I'm not quite sure. There might be a gray zone. The question whether growing pain can be a sign of occult tethered cord. It could be. I don't want to make the point that now all patients, with pain, growing pain should be screened by an MRI, but you should certainly be not dismissing it, and you should be very careful and maybe watch a patient, and if more symptoms occur, you should ultimately get an MRI or evaluate for tethered cord. There's a question of whether tethered cord can acquire, and yes, it can be acquired. probably that's what we have in EDS. And the stroke that I mentioned can occur also later. It's not always like right there. So that's why we are so concerned to miss the bus on tethered cord, because the stroke might cause the irreversible problems. There is the question of an elephant standing on my lower back. Not quite sure what to make out of this. It's a very interesting thing. Prevents one from standing straight. I'm not quite sure whether this is a sign of tethered cord. But for now, what I just said in my lecture, one has to gather all the symptoms in order to in the future to understand what might be tethered cord related and what not. Yes, and there's again the question. There's one patient who asked, or person who asked, a mother actually, that a daughter had a cranial stabilization surgery 3 months ago, and then she has now a lot of symptoms with tiptoeing, unable to walk flat-footed, looseness in her hips. Yes, I'm saying sometimes tethered cord gets overlooked and everyone focuses on the craniocervical junction, and when once that's taken care of, all of a sudden tethered cord comes to light just because there's different alignment of the spine. So my answer is yes, and it's certainly tethered cord is a strong consideration. I'm very worried about the tethered cord and that 23-year-old daughter that had a surgery 3 months ago. Question is of whether tethered cord presents with buttocks or lower back dimples. Yes. There's a question about a low histamine diet to prevent tethering. I don't know. And also I don't know whether tethered cord can cause women to have painful pap smears. I doubt, I have to say. I doubt. The question of retethering and what image to do. So it's about a child. I'm afraid in a child, the upright MRI is probably difficult to perform. I would definitely recommend it should be reevaluated for tethered cord, and certainly, I don't know whether urodynamic studies have been done, which are also not easy in a 5-year-old child, but you can only go by symptoms. I would just repeat an MRI of the lumbar spine and the thoracic spine to not make sure that there's anything else of a complication. But I guess one has to go by a thorough clinical examination, and if all the signs are back, re-exploration is warranted. The question is also whether I have any explanation for the traveling pain in tethered cord. It's because of the stroke in the tethered cord and the blood flow impairment. So it affects the cord on various areas, and that's why it travels. So the cord is not always just damaged or affected on one area. It's kind of, affects the cord on various areas. And that's why it's kind of changing from one day to the other, depending on how you move and where the blood flow is impaired on Tuesday versus Friday. It's just kind of a little sketch that I'm making up. The bulging disc mimic a tethered cord? No, a bulging disc cannot mimic a tethered cord. Sorry. And I guess I have to hold on. And there is a question. So I have to go to the bulging disc. So the bulging disc cannot. And a question: how do you distinguish between the trusor sphincter dyssynergia related to neurogenic bladder? Here I think, so I have to don't want to dismiss this question because that is really like a very good question. As I just said, I think what really represents the urodynamic problem EDS in relation to tethered cord will be something that also needs to be studied. I have encouraged my 2 urogynecologists here to do urodynamic studies as they would do, and we're just going to stretch the findings a little bit in the sense that I would not always expect to have classic urodynamic findings as in classic neurogenic bladder, and then we understand more looking forward and collecting data prospectively what is the specific urodynamic problem that we might be looking at in EDS in conjunction to tethered cord. So I think the final answer is not provided yet. It is too complicated. But again, for now, basically bluntly saying, any urodynamic finding I take now for granted that there might be an element of tethered cord. If the urodynamic study is totally normal, then I'm certainly guarded, but I wouldn't dismiss a tethered cord syndrome if the urodynamic study doesn't show like the classical urogenic bladder profile, because I think we cannot do that in ADS. Not quite sure whether I do see any relation with RCDS and tethered cord, and I think I'm almost through the list. I cannot answer the question about mast cell activation because that's not my expertise. That is something where I usually already have a patient that was tested for it by Ann Maitland or Claire Francomano in Washington, or sometimes here Dr. Pradeep Chopra has some understanding of mast cells, so I defer to my colleagues and the interdisciplinary team. I already had answered the question that I do think that rarely a fusion is necessary alongside with the tethered cord surgery, because the fusion should not be done proactively, because tethered cord release could align the spine better and improve the capacity of the paraspinous muscles, and by that mechanism strengthen the alignment of the spinal cord, and fusion is not necessary. Okay, I think I'm gonna there are some questions whether tethered cord can cause hyperlordosis. No, it's usually kyphosis or scoliosis. And the question is whether bulging discs are a sign of tethered cord. No, I don't think that bulging discs have anything to do with tethered cord, and bulging discs should have different symptoms than tethered cord. And the last question that I'm going to answer tonight is there an age range that adult patients notice OTC symptoms? It could be that you can develop OTC symptoms after the age of 40. That is possible because sometimes aging plays into the factor, and aging provides provides more fragile nervous system, and the nervous system can then all of a sudden become sensitive to stretching, and you can develop tethered cord with aging and after 40 years. Okay, I think I have to stop now. I'm sorry. I'm sorry that I cannot answer all your questions. I went through most of them.
Wonderful. Thank you so much. Well, we appreciate you coming to talk to us tonight, and also just, wow, so much information. I learned a lot, and there's a lot for me to digest and go back and listen to again. And I know a lot of the live attendees feel the same way. It's just we appreciate the high level of information, so we can learn a lot more about this. A lot of people aren't even aware of tethered cord and how it interacts with a lot of the other associated conditions with EDS. So we appreciate you also, collaborating with a lot of the other specialists with EDS too. Like our
very welcome. I know it was a lot of information, but I just wanted you to, I know you have the opportunity to go over the slides again, and I thought that, you should be all informed. I think that's the best important, because we need your help too, because we cannot do all this without you. And I hope that the more, that's why I felt it was good that you have some, depth inside and pleasure.
Wonderful. All right. Well, thank you on behalf of everyone attending live now. And as we mentioned, the recording will be available in the next couple of days on the same web page that people use to log in.
All right. And then I just said that people certainly they can find my email through internet, and if they want to have because there was some patients that were from out of the state. I'm very happy to help, but it's sometimes a little bit difficult to get that straightened out because of insurances. Sometimes they provide difficulties, but I'm very happy to make a consultation if someone wants to do that.
Okay, great. Well, and we'll provide some contact information as well for people along with the recording and the slides for tonight's presentation. And just a reminder that our next presentation will be on January 19th. We'll have Dr. Petra Klinge back again for a second presentation on feet and ankles. So don't miss that. And we want to thank everyone again tonight for joining us.
And I also wanted to thank Dr. this evening. And this is a topic that we have heard requests for, and it's really fabulous we've had an opportunity to hear some very detailed information about this subject. So I think this will be very popular with our ES audience, and thank you so much for your time and this valuable information that we can share with others in the EDS community. So thank you again.
Very welcome, John. Yeah. And have a good night, everyone. All right, we'll go from here. All right.
Okay.
Have a good night. Thanks for being with me.
I just want to remind people that this webinars are sponsored by Body Support Store, where you find over 250 products that are chosen by EDSers for EDSers. So please visit our store and check out the valuable, helpful products that we sell. So again, thank you for everyone attending, and have a pleasant evening. Good night.
Good night.
Good night, everyone.
Good night.